Hi, this is Michael Altos, and we are continuing our discussion of the coagulation system. This is part 3. The next class of drugs we'll discuss are the direct thrombin inhibitors. As we saw before, thrombin is one of the key points in the coagulation pathway. These drugs directly inhibit thrombin, and they include argatroban, dabigatran, which is Pradaxa, and bivalirudin, which is Angiomax. These are very specific thrombin inhibitors, and they also suppress platelet function. They can be used as an alternative to heparin, let's say in patients who have an allergy or HITT, and they can be used to anticoagulate even to the point where patients can go on to cardiopulmonary bypass or ECMO. And they can also be used in the treatment of an acute coronary syndrome. Classically, they've been titrated with dosing based on the PTT. And in case of the need for immediate reversal, some say that PCCs, the prothrombin complex concentrates, can be used to reverse them. There are also direct factor Xa inhibitors, and these include Xarelto and Eliquis. These drugs have very short half-lives and rapid onset of action, and in general, we don't monitor their activity. They don't have very many dietary interactions. They're approved for use in patients with HITT. And in case of bleeding, they can be reversed with PCCs according to some studies. There are also indirect factor Xa inhibitors. The most common is fondaparinux, which is Arixtra. This drug mimics the active binding site of heparin, and so it binds to antithrombin 3. It inhibits factor Xa directly, but not thrombin. It has a very low risk of heparin-induced thrombocytopenia and can be used as an alternative for both prophylaxis and treatment of DVT and PE. The guidelines about doing regional anesthesia in patients taking Arixtra are not clear. Most people suggest waiting at least 24 to 48 hours. It's excreted in the kidneys and may be reversible with factor VIIa. Most of the drugs that we just discussed are hard to memorize, and I would only focus on the most fundamental key points when learning them. I personally have to go look them up most of the time when I run into them, just to make sure I'm remembering which is which. Now we're going to talk about the anti-fibrinolytic drugs. These are drugs that are used both intraoperatively and postoperatively to decrease bleeding. And they've been used in a wide variety of settings, including cardiac, liver surgery and transplants, orthopedic surgery, pelvic surgery, obstetric setting, craniofacial surgery. These drugs work by forming a reversible complex with plasminogen, and they prevent plasmin from being activated, and they inactivate plasmin that is already free. All of these work to prevent the breakdown of clot, to prevent fibrinolysis, and thus they stabilize clot. Not surprisingly, the biggest risk with giving anti-fibrinolytic drugs is increased tendency toward clot formation, or thrombotic tendency. The two drugs that you're most likely to see are epsilon aminocaproic acid, which is Amicar, and tranexamic acid. And we think of these as drugs that help protect clot. Like we said, they prevent plasminogen from becoming plasmin, and they also inactivate plasmin. And the side effects, at least for Amicar, are some myalgias and nausea. As an example, we use tranexamic acid for joint replacement surgery at our hospital. We give a bolus of 10 milligrams per kilogram up to 1 gram. We give it after induction, but before incision, and give it over about 10 to 15 minutes. We repeat the dose unless the creatinine is greater than 1.5. And we don't give the drug to patients who have any risk of clot. So these include patients with a history of a DVT or a PE, coronary artery disease or an MI or a CABG, patients who have coronary stents, history of a stroke, or any other prothrombotic condition. We also avoid tranexamic acid in patients who have a history of seizure or any known retinal microcirculatory problems. There is one other anti-fibrinolytic drug called aprotenin. I don't think you'll see it on exams anymore. It's off the market now due to increased risk of MI and renal failure. As always, please let me know if you have questions about any of the content. I'd be happy to hear from you, or you can discuss them with me in class. Now we're going to talk about a couple of the uncommon, expensive drugs on the market. The first is recombinant factor Xa. This drug acts directly on factor X and activates it, thus initiating an immediate thrombin burst. It works without the presence of factors 8 or factor 9, which are the two factors that are absent in patients who have the two types of hemophilia. All it needs is some factor 5, factor 10 of course, factor 2, which is thrombin, fibrinogen, and at least some platelets. And if the patient has those, then recombinant factor Xa is a very powerful clotting drug. It's intended to be used for patients with hemophilia, but some have used it as the hemostatic agent of last resort in a case of uncontrolled bleeding. And it's been used in a number of different settings, including trauma, liver failure, GI bleeds, OB hemorrhage, intracranial hemorrhage, and transplantation. For a while, it was used to reverse warfarin overdose, but it's no longer recommended because we'll see there's a better choice available now. What dose should be used for recombinant factor Xa? Nobody really knows. Most recommend starting at a dose of 20 to 40 micrograms per kilogram if it's not an emergency, something in the range of 40 to 90 micrograms per kilogram for more urgent situations, with a maximum dose around 200 micrograms per kilogram. As a point of reference, hemophilia, the dose is 90 micrograms per kilogram. It has a half-life of 2 hours, which means it will need to be frequently redosed. And the last time I checked, it had a cost of about $1 per microgram. So as you can see, we can quickly spend thousands of dollars administering this drug to a patient. Since it causes the thrombin burst, thrombotic complications are the biggest concern, including stroke, MI, PE, and clotting of devices like an LVAD. It should be used with caution in high-risk patients, like those who already have coronary disease, cerebrovascular disease, or DIC. Prothrombin complex concentrates, or PCCs, under the brand name Kcentra, are FDA approved for treatment of hemophilia. But many have selected it as the drug of choice for the emergent reversal of vitamin K antagonists like Coumadin, and for management of critical bleeding in surgery, trauma, and liver failure. There seem to be fewer reports of significant thrombotic complications compared with factor Xa, and less risk of infection and other side effects associated with large doses of FFP. Usually Kcentra includes factors 2, 7, 9, and 10, plus an anticoagulant. Until 2013, there was only a 3-factor composition which lacked factor 7, and it was of much less use, but now the full 4-factor complex is available. The factors with the longest half-lives are factors 2 and 10, with half-lives of 60 and 30 hours respectively. So the need to redose this is much, much less than it was with factor 7a. The dose is 25 to 50 units per kilogram IV, infused at 3 units per kilogram per minute. And again, because it causes clotting, it's contraindicated in patients who have DIC and other high risk of thrombosis. The last drug I want to discuss is Desmopressin, DDAVP. This is a form of vasopressin, and it causes release of factor 8, von Willebrand's factor, and TPA, with some tachyphylaxis with repeat dosing. All forms of von Willebrand's disease, except for type 2b, respond to treatment with DDAVP. It also is useful in treatment of patients with mild hemophilia, uremia, and what's common in all of these situations is platelet dysfunction. So uremia, as well as antiplatelet drugs like NSAIDs and aspirin, dextran and Plavix, all may benefit from the administration of DDAVP if a patient is having bleeding. Now, DDAVP only acts at the V2 receptors, the vasopressin type 2 receptors. So we won't see the vasoconstriction that we see with regular vasopressin, but we will see the antidiuretic effect. And the effects last for about 6 to 8 hours. That's it for our discussion of the coagulation system. Thanks for your attention, and please give me some feedback if you have any questions, and we'll see you again next time.